Hi, thank you so much for joining. And I'm just seeing a bunch of people starting to pop in. So we'll give it just a second before getting started. But it's so nice to see you, and welcome to what my husband and I call the blue room, because the ceiling was painted blue when we moved in, and we kept it that way.
Well, we like blue as well, as you can see. So,
thank you everybody that's already joined this this event. I'm going to introduce the event, talk a little bit about the organization, introduce Dr. Shah, and then we'll dive as quickly as possible into the Q&A portion, which is really what I know everybody cares the most about. So my name is Megan Hansen. For those of you that don't know me, I am the co-founder and president of Recurrent Pregnancy Loss Association, which is a nonprofit organization. Actually, we just got our 501c3 approval this week, so that was like a huge milestone for us. So we're now like a legit IRS recognized nonprofit.
congratulations.
Thank you. And we're really dedicated to raising awareness about recurrent pregnancy loss, providing education and resources to patients, and then funding research into causes and treatments, because there are still so many women for whom this condition remains unexplained. Tonight's event, we're talking to Dr. Shah about testing miscarriage tissue and what it can tell you about the pregnancy that you've lost, but also how then it can help inform how you move forward with your care on this journey. And I want to say up front, and Dr. Shah and I were communicating about this via email. I know that this is a really sensitive topic to talk about, and even the language around it can be really triggering. So we'll just own that. And I know that it might be hard for some people to listen to, but appreciate you being here, because I think it'll be really helpful. So I will let Dr. Shah introduce herself in a second, but I find that really, really smart women are often too humble about all their accomplishments. So I'm going to do the formal intro so that you guys can have the full background of who we get to talk to tonight. So Dr. Meera Shah is a double board certified OB-GYN and reproductive endocrinology and infertility specialist, and she practices at Nova IVF in Mountain View, California. She completed her undergrad at UC Berkeley and then did a fellowship year at the National Institute of Health, where she was doing research into neuroendocrinology. She got her medical degree from Stanford and then did her residency at University of California, San Francisco, and then went back to Stanford to do her fellowship in reproductive endocrinology and infertility. She has contributed to publications on a number of topics, everything from fertility preservation for cancer patients to pregnancy loss, to reproductive genetics, to ethnic differences in IVF outcomes. And her research thesis actually focused on comparing different genetic testing platforms to understand the causes of early pregnancy loss. And so, as you can imagine, that makes her sort of the perfect person to be talking to us tonight about miscarriage testing. If you don't follow her on social media, you should start now, because she posts great content and is really good about educating women about their fertility. And also then she is the mother of 3 boys and has also been very open about her own fertility journey and struggle with pregnancy loss. So Dr. Shah, I'm so glad that you are here with us, and I'll let you also give any additional introduction that you'd like to about yourself, why you chose this specialty, why you chose your thesis topic, and anything else.
Thank you so much for that wonderful introduction. Well, it's great to be here, and I'm really glad to be a part of this conversation today and be spreading awareness on a really important topic that is something I talk about daily in my practice, and also something that's deeply personal to me, as I'll share with you later on. So I joined this field of, OBGYN because I'm passionate about women's health. And I feel like it's such a privilege to be part of a woman's life during very vulnerable moments, whether it's puberty, adolescence, pregnancy, talking about contraception, going through menopause,
Yep.
infertility, talking about cancer, ovarian cancer. So we really get to touch women's lives at very intimate parts, and it's truly a privilege to do that. And when I was doing my OBGYN training at UCSF, I realized that it was going to be really hard to master everything, and I wanted to really be a specialist in something very specific. And I found that the field of fertility was incredibly intellectually interesting. The endocrinology is fascinating. It certainly was extremely rewarding in terms of the end goal of fertility treatment, which is helping couples build families. And it's really a technical field too. There's a lot of surgery and procedures involved. And so it really had everything that I was looking for. But most importantly was the relationship with the patient, which involves so much continuity of care. We often have patients that go through years of treatment. And so you really, really, truly have a special relationship with every couple that goes through treatment. And so I truly have found my calling in this field. And I feel even sort of more lucky to be in this field because I have a unique perspective on it as being a patient. And to share with you all, I personally experienced recurrent pregnancy loss. And in fact, have had 7 pregnancies resulting in 3 healthy babies, but my 4 losses were devastating. And I'm happy to share more about that as we go through the Q&A. But I think in experiencing that myself, it allowed me to be more compassionate as a provider. Yeah. It allowed me to truly understand the struggles of going through a pregnancy loss and what it takes to heal and move forward. And so as much as I wish I didn't have to go through that, in some ways, I think it almost helped me become a better provider and doctor and human. Yeah. I think we oftentimes want control in our lives, and this is one of those things that you don't have control over at all, for the most part. We'll talk about some things you can take control over, but in large part, this is something you don't have a lot of control over. And so in a lot of ways, this was a life lesson for me each time, that sometimes you just have to have grace in this process and continue to have hope and believe that things, there can be a rainbow at the other side of it, which it certainly was for me. Yeah. And so really that's really where I feel I've had a passion within my field, is in pregnancy loss, and specifically recurrent pregnancy loss. And I was really lucky to have a wonderful research mentor at Stanford. Her name is Dr. Ruth Lottie. She is the director of the Recurrent Pregnancy Loss Program, and she does a lot of research in this field, and she was my research mentor. And she and I really were interested in looking at products of conception testing. Now, I know that's kind of a technical term, so I'll refer to it as just miscarriage tissue testing. And essentially what we were interested in looking at in my thesis project was the different ways you can test and which is the most accurate, and sort of just gauging in the community how often it's utilized. And unfortunately, it's heavily underutilized. And that's something I really try to advocate for in all the lectures that I give and the outreach that I do, in the social media education that I do. I want both women going through this to know that there are options, and also for providers who are counseling women through a pregnancy loss to know that there are ways to find answers to understand what caused a pregnancy loss.
Yeah, no, I think that's so important. And I'd be curious to know kind of the information about your thesis, about like the different types of providers and sort of like who is frequently requesting testing, who, like, why and why not. But let's not go there right away. I guess going back to the beginning, let's just start at the basics. So when you're doing testing on miscarriage tissue, what exactly are those tests looking for? What are you trying to determine? And as you said, there are different types of tests that you evaluated as part of your thesis. What are the different tests looking for?
Okay, so one of the first things to explain up front is the concept of a clinical pregnancy.
Mhm.
And this is different than a biochemical pregnancy, which is defined as the pregnancy hormone being detected in the blood, but it doesn't progress to a point where you can actually see anything in an ultrasound. So a clinical pregnancy is defined by a positive HCG level, in addition to signs of either a fluid collection or gestational sac in the uterus. Sometimes if it progresses further, you can see a yolk sac or fetal pole. Anything essentially that can be visualized in the uterus is called a clinical pregnancy. And unfortunately, you cannot do any testing on a biochemical pregnancy. There's just simply not enough tissue to test for, but you can do a variety of different tests in a clinical pregnancy loss. Most pregnancy losses happen between 6 and 8 weeks.
Mhm.
And the majority of those pregnancy losses are due to chromosomal or genetic issues. So another thing I want to explain to our viewers is how to think about genetics, because this is a really difficult concept to understand, and it helps us to understand how these tests work. The way I wanted to explain it to our viewers is a normal number of chromosomes is 46. We inherit 23 from our mother, 23 from our father. So the analogy that I often use to my patients is imagine a bookshelf of encyclopedias. You
Yep.
have 23 that are inherited from one parent, 23 from another parent. And so you can count the number of encyclopedias on that shelf to determine the total number of chromosomes. And so a condition that many people are familiar with is Down syndrome. That's if encyclopedia number 21 was duplicated. So you have an entire set. So you have 47 books on yourself now instead of 46. Okay.
Yep.
And that obviously leads to, actually, in most cases, miscarriage, but obviously could progress to a live birth as well. Now, a lot of times people wonder what is the difference between looking at, genetic testing of, for example, in my field in IVF, looking at something like cystic fibrosis or sickle cell disease. And those are specific genes within a chromosome. So imagine that within the text of your encyclopedia, you've got your letters. And if one letter switches to another letter, that can cause a genetic condition. So the way that I talk about genetics is really on a macro level, the number of books on the shelf, and on a micro level, looking at the letters within each encyclopedia text. So when we're talking about products of conception testing, there's really two things we can test for. One is genetics, and we'll talk about the different types of genetic testing that we can do. But you can also just generally do pathology testing, which is just looking for the presence of something called chorionic villi. Chorionic villi is essentially the early parts of the placental tissue that are supporting the fetus's growth. And
Okay.
so while you can't actually see a fetus at 6 or 8 weeks, I mean, it's microscopic, you can actually visibly see the chorionic villi. And because in most cases, the genetics of the placenta and the genetics of the fetal tissue are concordant, you can actually test the placental tissue, and that's a surrogate marker for the genetics of the pregnancy. Okay,
Yep.
so what we're doing in miscarriage tissue testing or products of conception testing is looking at that specific chorionic villi, the placenta tissue. Okay, and so going into sort of genetics in more detail, there are different ways to test the genetics of the tissue.
Okay.
So the sort of gold standard method is something called a metaphase karyotype. Metaphase karyotype is essentially where you take the cells, you take about 20 or 30 cells from that placenta tissue,
Okay.
and you essentially stain the chromosomes with a specific type of stain. And if you imagine back to our encyclopedia analogy, you can imagine that different sentences might have more density. Some sentences are maybe more spread apart. So essentially, there's a specific banding pattern that looks at the density of those letters within the chromosome. And so essentially, it's actually a visual inspection of each of the chromosomes to actually count up the number of, again, encyclopedias or
Yep.
chromosomes, and to also look at arrangements of the DNA within the chromosome. And that's something that is especially important in couples who've experienced recurrent pregnancy loss, because in a small subset of those patients, they can have translocations. In other words, parts of their DNA, maybe chapter 4 in the encyclopedia is now in chapter 12 and vice versa. And that's going to result in abnormal, essential development of certain structures and ultimately a pregnancy loss. So the beauty of a karyotype is that you can actually look at the pattern of that banding. You can look at the location of certain genetic parts of the chromosome, and you can get a lot of information from that. So that has really been the gold standard in our field. Now, some of the limitations of that testing is that it takes a really long time. It takes about a month to 2 months to get those results back. That's a long time for a couple who's recently experienced a pregnancy loss to get that information back.
Yeah.
The other issue is that in many cases you don't get a result because you're relying on a culture environment, and sometimes those cells are not healthy enough to continue to divide. You're relying on that amplification to essentially allow you to do that testing, right? And so if they stop growing, you're not going to get a result. And that can be really frustrating to a patient as well. Another thing that's sort of interesting is that a woman's DNA contains 46 chromosomes, and the sex chromosomes are XX. Right. Now, if the fetal tissue was also a female fetus and its genetic composition was 46XX, you wouldn't actually be able to tell the difference. So there's something called maternal cell contamination, which is essentially when, there's obvious DNA from the woman carrying that pregnancy that is in that tissue. You can't differentiate fetal tissue from maternal tissue. So those are some of the strengths and limitations of the gold standard karyotype. Yep. Now, some of the newer methods, which I'm a big advocate for a lot of reasons I'll go into, are molecular methods. So this is where you actually, instead of sort of just visually inspecting the DNA, you're actually sequencing parts of the DNA, and you're looking at the ratios of certain types of DNA to determine whether there's a normal ratio of chromosomes. And so one of the huge benefits of this is, number one, you don't need a lot of tissue to test using these molecular platforms. And so you're much more likely to get a result. Got it. The second thing is that you can detect abnormalities on a very, very microscopic level. So, small deletions or duplications in DNA can be detected by these methods, which can't be detected using the other method that I explained before. One of the other, I think, incredible benefits of this is that you can get the results back within a week. And for a couple grieving who's recently encountered a pregnancy loss, again, getting a result, which in most cases is going to be abnormal. In fact, about 70% pregnancy loss you can find determined to be due to a chromosomal abnormality. If a couple gets that, it allows them to find closure in that loss. And finding that earlier on can really allow them to begin healing and to begin to potentially explore other options in terms of their next attempt. So that's a basic overview of the different platforms. Some of the companies that I've used in my practice that do that molecular method, two are Natera and iGenomics. They are two companies that we work with a lot, and I've had a very good experience with getting results from them within a week, and very, very accurate results. And these were platforms that I used in my thesis as well. And I really do think highly of the integrity of their results.
Okay. And I can I'll post that on our account so that people have that, because I think that, if you're going in to talk to your doctor, to be able to say, what type of test are you actually performing, and who's the company that's creating that diagnostic, I think it's helpful for people to be able to ask for. That is a super helpful overview. So, I love that encyclopedia analogy, sort of being able to say, is this test looking to see are all the books on my shelf, or is this test looking to see, is there something missing from one specific book? I think that's I've never heard that before, and I think that's a really, really helpful way to think about it. So thank you for that analogy.
Of course.
Could you... I think one of the, and I also appreciate understanding the difference between how many cells are required to be able to perform the various tests. Because I think one of the things that comes up for me, and I think a lot of patients that have lost pregnancies, is well, how exactly are these samples collected? And I think people are aware that if you're getting a DNC, obviously you can collect tissue that way, but what if people are experiencing a miscarriage naturally at home, or they've opted to do a medical miscarriage? Logistically, how can this be done? So maybe I'll ask you to talk a little bit about that process and pros and cons of different options.
Yes, that's a great question. So ideally, the best specimen to have the highest chance of getting a result is from a DNC, but not every patient has the opportunity to get a DNC. And as you mentioned, a lot of women pass these pregnancies naturally.
Mm-hmm.
Now, the good news is that there's still the ability to do testing, genetic testing on that tissue, even if a woman passes the tissue naturally.
Yeah.
And in some of cases that I've been involved with, women essentially can collect that tissue in a container and provide it to their doctor. And essentially what I'll do is I'll go through the tissue and try to identify that chorionic placental tissue. And oftentimes I'm able to, but sometimes I'm not. And in those cases, unfortunately, we're not able to get the results. So again, in my thesis, actually, we performed DNCs on all the women who enrolled in the study. And one of the benefits of that was that for women who encountered a very early pregnancy loss,
Mm-hmm.
like even as early as 5 or 6 weeks,
yeah.
and their gestational sacs were really small, by doing a DNC, we were able to collect enough tissue. And because the tissue was a fresh sample, we were able to get results in 100% of cases.
Oh, wow.
So, I am an IVF physician, so I obviously monitor my patients extremely closely. I do ultrasounds a week after a positive pregnancy test, 2 weeks after a pregnancy test. So I have the luxury of being able to diagnose a miscarriage much earlier than for most women in the general community, who likely won't find out until maybe it's already happened, weeks later sometimes. Right. So in my practice, I do offer women all options because I think it's important that we give women the options to do it more naturally or to do a DNC. But I think if women do want to get information about, or couples want to get information about the genetics, doing a DNC, especially if it's happened very early on, is much more likely to yield a result. Yeah.
And even sort of the follow-up question to that, even, I appreciated kind of the explanation up front about clinical versus biochemical pregnancies, but I know that there are probably women that are losing pregnancies if they're still working with an OB, if they haven't gotten to the point of seeing a specialist, and they're losing a pregnancy within that 6 to 8 week kind of time frame before they've had a first appointment. It might still be possible to collect sample at home and request it to be evaluated.
Absolutely. It's still very possible.
Okay. Yeah, no, that's really helpful information. And if somebody was doing that, they store it in the refrigerator and then take it to the doctor's office. Okay.
Exactly right. And going back to the methods I explained earlier on, because of the nature of that tissue, and the integrity of that tissue, you would have to do a molecular test on it to get a result. You wouldn't be able to do the karyotype because for that, you really need a lot more tissue. But that's, again, one of the beauties of doing molecular testing is that you can use an older sample. It doesn't have to be fresh, and you only need very, very small amounts of DNA to get a result.
Okay.
Yeah.
And then I just did want to talk about, I know, and it didn't actually come in a question this time, but as we're talking about DNC procedures, I know, especially for, I think, women in the recurrent pregnancy loss community that usually are dealing with like multifactorial issues going on. Do you have any thoughts about DNC as it might relate to fears or concerns about scarring and scar tissue buildup?
So to answer that question, I'll start out by just talking about the options that women have in managing a miscarriage. So in most cases, a miscarriage is not a life-threatening event to a woman. It's very rare that she experiences so much bleeding that she has to go to the emergency room and get a blood transfusion. That's exceedingly rare. So most women do have options because they do have time to process and decide what's best for them. I do offer women 3 options. The first option is to naturally allow the body to take its course. And in about 60 to 65% of women, that will eventually happen. Yep. The benefits of that is really that it is natural. No procedures are needed. But the flip side is that you don't know really when it's going to happen. And I think that uncertainty for a lot of women is troublesome. So I tell women it could happen in a few days or it could happen in a few weeks, and you just have to be prepared for that. But like I said, it could be very effective and prevent, women from having to undergo a medical procedure. The second option is using a medication called misoprostol, which is a medication that helps to dilate the cervix and contract the uterus. and it usually works within 24 to 48 hours. So it's extremely effective, and it works in about 80% of cases. And again, women can be in the comfort of their home, they can be with their partner, they can be around people that can support them during that period of time. And usually women will experience a couple hours of heavy bleeding. They'll pass, everything, and then it'll be completed, and they will continue to heal very quickly from that point onward. And then the third option is doing a D&C, which is nearly 100% effective in removing all the tissue. The benefits are being able to do genetic testing on that tissue. And me personally, and I'll share this with our viewers again, I've done all of those options. I've waited. Okay, so maybe I'll ask you what your experience was too. But I tried it naturally. It didn't happen. I took misoprostol. It didn't work. And then finally, I underwent the D&C. And I will say personally, my experience was that was really the best option for me because it was the fastest. It allowed me to heal the quickest. My hormone levels returned back to normal within a few weeks. And most importantly, I was able to get genetic information. And in my case, it did determine that there was an abnormality, which really allowed me, again, to find closure in that process. So again, women have options, and oftentimes I'll present women with the option to, especially if they're less inclined to undergo a D&C, I'll have them take misoprostol, or try naturally for a few days. If it doesn't happen, take misoprostol. If it doesn't work, the D&C is always their last option. But I do present women with all those options so that they know that they're in the driver's seat and they can control what happens to their body in this process.
Absolutely. Yeah, no, I'm not sure that I have a preference. There were a couple of occasions where the option was made, or the decision was made for me because my body naturally just lost a pregnancy. But I think, it's I guess for anybody that's viewing and is fretting over this decision, it's a very personal one. Talk to your doctor, and whichever option you choose, you can still move forward with testing if that's the choice that you're making, as you already spoke about.
Sorry, and I didn't get to answer your last question, which was a lot of women worry about the damage of their uterus in doing a D&C. And I can reassure everyone out there that the instrumentation that we use to do a D&C is extremely gentle. We don't want to harm the uterus in any way. So even just the instruments that we use are extremely gentle. And yes, of course, for women who've had repeated D&Cs, they are at higher risk for a condition called Asherman syndrome, which is essentially a scarring of the tissue. But that is pretty rare. I would say that the vast majority of women heal and their uterus is able to grow a new lining within a matter of a month or two. So it really is a safe, quick procedure that, and it typically is done under anesthesia, so women don't have to experience the pain of that. And I think that's another really important part of why women opt to do a D&C over other options. They don't have to go through the trauma of that experience.
Yeah, absolutely.
Yeah.
Now that you've kind of given the background of what are the options sort of leading up to collecting the tissue and the different types of testing options for that analysis. So now those results come back, and either something looks abnormal or something doesn't. So can you talk about what do the results then tell you, and how do you move forward with patients based on those results?
That's a great question. So like I mentioned before, about at least 70% of pregnancy losses are due to chromosome abnormalities. And so oftentimes when I'm providing patients with that information, I can tell them, well, this was the cause of your pregnancy loss. A lot of women feel like their bodies are failing them. And I think learning that it was the embryo and it was a genetic issue with an embryo that was a sporadic biological process that they had no control over caused the pregnancy loss, I think, again, helps reduce that self-blame, which is incredibly important in the process of healing. So in 70% of the time, I think I can reassure women that this was the cause. When they get pregnant again, it's unlikely for them to have this happen, a second time. And I always reassure women of that, regardless of how many miscarriages they have experienced in the past. When they get pregnant again, the chances of a live birth are extremely high.
Yes, I feel like we should pause and just make sure that everyone hears that. Even if you've had 5, 6 losses, the odds are still in your favor that your next pregnancy will
Yes. And
These
you know what? I actually printed something out. It's on one of my Instagram posts. And I don't know if the viewers can see this, but there's a graph here. And on the y-axis is the live birth rate for
Mhm.
unexplained recurrent pregnancy loss. And on the x-axis is the number of pregnancy losses that a woman's experienced. And these are different age groups. It's 20, 25, 30, 35, and 40. And just to give you some reference, this is 50%, okay,
Yeah.
this line right here. So even for women who've experienced, who are like 35 years old, who've experienced 3 or 4 pregnancy losses, on their next attempt, if they get pregnant, their chance of having a live birth is over 50%. So this is data that this is data, this is science,
Yeah.
this is real. And I think this data really gave me hope in my own personal struggles when I went through pregnancy loss, to know that the next time, even though I had so many prior losses, that the next attempt was more likely to be successful than result in another pregnancy loss. And
Yep.
that's so important for couples to understand.
Yeah.
But going back to your question, I think one of the struggles that I have is in talking to women who've experienced a pregnancy loss where the tissue is normal.
Yeah.
That's a really hard conversation to have, because I don't always have the answers then.
Yeah.
And then we sometimes go exploring other things. Like I will do oftentimes a full pregnancy loss evaluation where I check thyroid levels, I check for a diabetes screening, I do vitamin D levels, I will do a very thorough uterine cavity evaluation. I will
Yep.
check for autoimmune conditions that are grouped under a condition called antiphospholipid syndrome.
Yep.
A very small minority of women who experience pregnancy loss will have any abnormality. But even if there's anything to optimize for, I will look for that as they
Yeah.
begin to plan for their next attempt. But oftentimes we don't have the answer,
Yeah.
especially in those pregnancy losses where the genetic tissue comes back normal. And what I tell most of those women and couples is that even though we may not have an answer with the genetics, it still was much more likely to be related to that embryo. Something about the mechanics, or maybe some non-genetic factor, resulted in that pregnancy loss. And again, if all the other tests came back normal, chances are that on their next attempt, they are going to be successful. But I
Yeah.
will admit that's a hard conversation to have with patients, and I don't always have those answers.
Yeah. And I'll say to anybody that's watching, obviously, if you've experienced multiple losses, and certainly if you've experienced losses that you had tested and did come back normal, recurrent pregnancy loss, the kind of causes are it's very heterogeneous condition. All patients are not the same. So fortunately, Dr. Shah and I can't get into all of that in this conversation, but for future conversations, we can dive deeper into each of those underlying causes. So, and that, I guess that's helpful. And in for those patients where some of the questions that came in actually from followers before this conversation were then around the IVF process and pre-testing and as it related to loss.
Mm-hmm.
So before even diving into real specific IVF questions, what is how do you counsel patients that have had multiple losses that are thinking about doing IVF to try and reduce that risk? I know the feelings in the medical community are very mixed, and so I'd love you to give us your kind of thoughts on that.
It is very mixed.
Yeah.
It's extremely mixed. And I think there's a couple of reasons for that. The first is that not everyone's a good candidate for IVF.
Okay.
Right? To be a good candidate for IVF, you have to have good egg supply, so ovarian reserve, and you have to have good genetics, which are related to your age. So, perhaps like a 34-year-old with a good ovarian reserve might be a good candidate for IVF and genetic testing. But someone who's 41 with a diminished ovarian reserve may not. And her chances might actually be better with natural attempts than they would be with IVF. So it really, really, really is specific to so many factors, but namely age and ovarian reserve. The other thing that I always talk to patients about is that genetic testing in IVF is not perfect.
Okay.
And even when you do IVF and genetically test an embryo, there's still a risk of miscarriage. That risk of miscarriage is low, it's about 10%. And that is lower than the risk of miscarriage in a natural conception or if genetic testing is not done in IVF. So I think that's really important. I think especially for a lot of couples who are traumatized by the experience of their prior loss and they want to take every action possible to minimize the risk of recurrence. So to those patients, I say, well, I understand that there are limitations to IVF, but given that we want to take every effort to minimize the risk of recurrence, I think IVF makes sense. There was actually a really well done study at Stanford done by a few of my prior colleagues there. And they essentially randomized women with recurrent pregnancy loss to IVF with genetic testing versus expectant management. So those couples would just continue to try on their own.
Right.
And the findings were contrary to what you might think.
Yeah.
So the women who the couples that did expectant management, they just continued to try naturally on their own. They actually had the same time to pregnancy, but obviously they didn't have to go through IVF. Certainly they didn't have to pay a dime for any treatment, and they had the same live birth rates as the IVF group.
Yep.
So that's really interesting. The outcomes were actually the same.
Yeah.
And that's why it's so controversial. And I think what you have to really parse out in that study is, again, not everybody is a good candidate for IVF.
Sure.
And it takes a couple of months to go through the IVF process. And I think what I've seen in my practice is that couples who have recurrent losses, who then go through IVF, genetic testing, and embryo transfer, spending tens of thousands of dollars on that process, and then have a negative cycle or, an outcome that's not a live birth, it almost hits them harder because they've taken all this, used up all these resources, emotional, financial, to make this process work. And when it doesn't, which oftentimes it doesn't, it can be really devastating.
Yeah.
So I think I really counsel patients really open and honestly about the limitations of IVF.
Yeah.
And I really take a lot of variables into consideration, including age and ovarian reserve. But one of the questions I ask up front to every couple that I see is, what are your big picture family planning goals? Because for a couple who doesn't have children and they want to have 2 kids, and maybe they're 38, 39 years old, to them I say, maybe trying naturally will get you pregnant successfully, but you're going to have a really hard time getting pregnant with your second kid. And I'm always thinking about short-term and long-term goals with all of our patients. And so I counsel those patients that IVF can be used not only to genetically test embryos to reduce the risk of miscarriage, but to store some embryos in the bank so that if you get pregnant, hopefully you have some embryos to use in the future for a second kid when it might be harder to do IVF at that point. So it's not a clear answer to your question because it really is done on a case-by-case basis, factoring in all these really individual variables. But it's a really good question. The take-home point is to really understand that this is extremely gray. This area of IVF and genetic testing, whether it benefits people with recurrent pregnancy loss, is not black or white. And so it's important to have a doctor who really can walk you through those steps, be open and honest about if this process is likely to work given the variables for that patient, like ovarian reserve and age. And then again, setting expectations. I think that is the name of, the key to this process is really understanding that sometimes it works and sometimes it doesn't, but there are pros and cons to each of those options. Yeah.
No, well, thank you for that. I think that's a beautiful answer. And I think it's really validating also to hear that perspective, because I do think that for patients that have maybe, or I shouldn't even call us patients. I kind of hate calling myself, experience of being a patient does make you feel like there's something wrong with you sometimes. But, for women that have maybe been working with their primary care OB in the community and are debating whether or not they want to see a specialist, I do think that sometimes there's fear about, if I'm going to go to a fertility clinic, I'm going to have to do IVF. And so what you just said is lovely to say, this is really based on and women's and a couple's goals for their family building kind of over time, and that it doesn't necessarily mean that you have to go path if you're seeking specialty care.
That's exactly right. I think I speak for most of people, my colleagues who practice REI, that, we don't recommend IVF to everyone. We shouldn't, because it doesn't necessarily work for everyone. And I always offer patients options. And one of those options is to try naturally.
Yeah.
And for some of my patients, that's worked, and they've avoided having to do lots of treatment and spend a whole lot of money on a treatment that, they really didn't need. So I think it's important
Yeah.
to find when you do see a reproductive specialist, to really not feel pressured into going into a specific treatment, and
Yeah.
to really feel like you have options and can make a educated and informed decision based on the counseling that you get.
Yeah. Now I'm going to go, even though we just talked about this, I'm going to go back to the IVF question, in the sense that for couples that have had recurrent loss, that have decided to go that route and have their embryos tested, if they then experience a miscarriage after a transfer with pre-testing, you had mentioned that the tests aren't perfect. Do you still recommend testing of the tissue at that point?
I do. And something to know is that a lot of the companies that do genetic testing of embryos, if
Mm-hmm.
there is a resulting miscarriage from that embryo transfer cycle, they will offer free testing of that miscarriage tissue. So I've worked with a lot of those companies, and I think that's wonderful because it can help certainly provide them some data on the accuracy of their testing,
Yeah.
and certainly can reduce the financial burden on the patient, the couple. In the study that I did at Stanford, a few of the patients recruited into our study were women that had undergone IVF and genetic testing. And in a subset of those couples, when we did miscarriage tissue genetic testing, we found something called mosaicism.
Okay.
Mosaicism is this concept where if you take like 100 cells from a tissue sample, some of the cells might be normal. They might have that 46 encyclopedias on the shelf, and then maybe another subset of those cells have 47 or
Okay.
44. And so it's a mix, and that's called mosaicism. And that's actually a natural biological process. And the body actually has mechanisms to self-correct as the embryo grows and the fetus develops. But what we found is that in a fair number of those patients that did IVF and genetic testing that resulted in a miscarriage, many of those couples had tissue that displayed mosaicism. And that certainly could have been the cause of their loss. So that's one reason to do testing, even if you've done pre-implantation testing. Okay. And, just for our viewers who are not familiar with what genetic testing of an embryo is, it's important to really understand this because it helps you to understand one of the limitations of the testing, which is that in an embryo that you test, you're maybe sampling like 5 or 6 cells out of the outer shell of the embryo. So at the blastocyst stage, which is the day 5 or day 6 embryo, the embryo is maybe 100, 150 cells, and it has 2 distinct parts. It has an outer shell called the trophectoderm. That cell line becomes the placenta, and then you have a little clump of cells inside the embryo called the inner cell mass. Those cells become the baby. And so when genetic testing is performed in an embryo, you actually biopsy that outer shell because you don't want to disrupt any of the cells inside.
Yep.
But that potentially could lead to some discordances, because if the placenta tissue has a genetic composition that's different from the fetal tissue, you might be getting a false positive or a false negative result. And again, that's looking at placenta tissue, so you may not be getting an accurate representation of the viability status of that embryo. So it's important to understand that. And, again, this is why we recommend for all pregnant patients who do successfully get pregnant with IVF and genetic testing, we do tell them to undergo the routine genetic testing in pregnancy, which includes the NIPT, or non-invasive prenatal testing,
Yep.
all the first and second trimester serum screening, because you might have missed something. While it's very rare, you still want to go through all the routine testing just to ensure that the rest of the fetus and the rest of the baby is genetically healthy and normal.
That's I think that's really helpful, and it maybe leads me into another question, which is kind of similar to the one I just asked, like sort of a specific question. But if a couple has gone through IVF and unfortunately had a miscarriage and did that testing, not the pre-testing, but tested the tissue, and the tissue came back normal, do you recommend that then they do any pre-testing on additional frozen embryos? Or, I mean, I know that's kind of a specific thing, but I think there's a question of like, is the benefit on the testing of the miscarriage tissue or on the pre-testing side? And how do you navigate depending on what?
Yes, that is something I encounter often, and it's a hard again, decision to make,
Yeah.
because again, like everything in medicine, there's pros and cons to that. So to sort of distill that down to a few points, if a couple has experienced a pregnancy loss from a IVF embryo that was not genetically tested and it was abnormal, going back and testing those remaining embryos, it certainly could give you more information that could reduce the risk of miscarriage, but it is doing additional interventions that could compromise the viability potential of the embryo.
Okay.
So it would require thawing it, biopsying it, and refreezing it. Now, if the embryos were frozen initially at the blastocyst stage, all of that would take place on the same day. So that's going to be potentially compromising to the embryos. In our practice, we do a lot of blastocyst cycles, but we also do a lot of day 2 and day 3 embryo freeze cycles as well. For those patients, I think there are more options, because to test those embryos, you would thaw them at day 3. You would give them a couple days to acclimate, then biopsy them when they made it to blastocyst, and test them and refreeze them. And that additional few days of letting them culture out really doesn't compromise the potential of those embryos. So there's a lot of factors that go into making that decision.
Got it.
The other thing that's really important is age. So if the couple's age, where the female age is under 35, the likelihood of another pregnancy loss with one of those remaining embryos is really low. Okay. This is something that I tell every couple who's experienced a pregnancy loss, which is that the body has incredible mechanisms to prevent abnormal pregnancies. Obviously, things can slip through and you can have a baby with a genetic abnormality, but in 95% of cases of a genetic issue, the body is going to either reject that embryo before implantation, or it's going to result in an early pregnancy loss between 6 and 8 weeks. Yep. So the fact that pregnancy is even developed to 9 weeks where you can do testing, you passed a lot of hurdles that decrease the pretest probability that pregnancy is going to be abnormal. So I do reassure women that if they get pregnant on another attempt with an untested embryo, chances are that embryo is healthy and normal. Yeah. Now, again, that applies more so to women maybe under 35. For women who were older and especially in their early 40s, I do, for those women, tell them that the risk of another miscarriage is certainly higher with an untested embryo. So for those couples, I might encourage them to consider doing it, but certainly I would review with them the limitations of testing, which is, number one, that there's a significant attrition rate in doing genetic testing. There's also inaccuracies in results that result in false positives and false negatives. So there has to be a comfort level with knowing that there may not be a viable embryo transferred because of a falsely reported result. But the trade-off is that you're transferring an embryo, which is going to have a higher potential and a lower miscarriage rate. So it's a very nuanced conversation, and there's a lot of things that go into that decision. But it is something that I do discuss with patients who've encountered a pregnancy loss after IVF without doing PGT upfront.
No, that's, thank you. I think that was a really, I don't think any of these questions are really like cut and dry answers. So like everything, even with recurrent pregnancy loss in general, I think lives in that gray area. And so I think it's so honest to be able to, everything's pros and cons. We're nearing sort of the end of the hour. And so I want to maybe like bring it back up to the high level and just say, what general advice do you have for women and couples that are going through this RPL journey? Advice from having experienced it yourself and now a doctor that's treating families that are in this situation. And what advice might you have for your other colleagues that are REIs or OB-GYNs that are working with these families?
I'll answer the second question first, which is the easier of the two. So I do encourage all OB-GYNs to offer their patients products of conception testing, because I think that information is so valuable in counseling and helping those patients and couples find closure. If they are then referred to us for additional treatment, having those results can certainly help us come up with a very clear game plan as to whether we're going to do genetic testing in IVF or not. Yep. So I want to really encourage and get the word out that everybody should be offered testing. Unfortunately, in some of the studies that we looked at, only 8% of women were offered testing. Yep. And that's just the reality. Most of the patients that I see who've had miscarriages were not offered testing. And I think we just need to get the word out and encourage people to offer it, and also have patients be their own advocates and know that these options are available.
Yeah.
So now, what personal advice would I give? I think, everybody heals differently after experiencing a pregnancy loss. And what I would tell those women out there and those couples out there is that time does heal. I think, in the immediacy of experiencing a loss, it's overwhelming. You feel a loss of control. You feel a level of desperation for getting pregnant again. There's so many feelings that just go through your mind. And I think that, for me personally, going through this, even a week later, I felt better. 2 weeks later, I felt better. And, by 4 to 6 weeks out, which is typically the amount of time that your body takes to physically heal from a pregnancy loss, I think emotionally you've recuperated quite a bit. There's always going to be a void. There's always going to be a sense of grief that you're going to feel, and there's going to be triggers, and you're going to hear about your friends getting pregnant, and it was so easy for them, and they've had no history of pregnancy losses. But what I will say for me personally is that time healed every time. I found the hope from sharing my experiences with friends and family. Now I'm much more open about it than I have been before, and I think I found tremendous support from colleagues, friends, family members. And, I think that it's important to find that support, whether it's through therapy, friends, I think there's various ways to find that support. But I think it's important to find a provider who is going to be your cheerleader and to give you that motivation to try again. And I think that a lot of women will have success if they do continue to try again.
Yeah.
Yeah.
No, I really, I appreciate, it's my own personal lived experience too. And it's, when you're in the middle of the story, it's hard to see the end. And you think that the grief is sometimes just absolutely suffocating, but time does, lift the heaviness of the burden, and though it always kind of remains. I agree with you 100%.
Yes. And I do think, again, while I don't wish this on anyone, and certainly I wish I didn't have to go through this experience myself, I feel it does make us better humans to understand the struggles of the fertility journey. I really do believe that we become more compassionate, we become more understanding, we certainly allow ourselves to become better healers to other people going through this.
Yeah.
And so there are some silver linings. Certainly when you do get pregnant again and it results in a healthy baby, I think the appreciation that you have for that is tremendous. So while it certainly is devastating when you're going through it, if you are fortunate to have the rainbow baby, I think it's incredible. And it allows you to be a much more compassionate human.
Yeah, I agreed. Dr. Shah, thank you so much. I just have really enjoyed chatting with you, and obviously you're brilliant. And so all of the information that you shared with us tonight, I think is so useful. For people that joined a bit after the fact, I just want to shout out, if you're not following Dr. Shah on Instagram or other platforms, Dr._Meera Shah, and she posts wonderful content and educational content for patients and also for other practitioners. And I just will close with a very brief plug for Recurrent Pregnancy Loss Association. So if you don't follow us, please do follow us. We're going to be trying to host more of these types of events throughout the course of the year on different topics specific to recurrent loss, because as we mentioned tonight, it's really heterogeneous and multifactorial condition. So we'll try and hit some other topics in a little bit more detail, like we were able to tonight with testing. And this is a really underfunded area of healthcare in terms of research going into infertility, and certainly research going into miscarriage and women's health in general. So if you're so inclined to make a donation to help our organization be able to fund research into recurrent pregnancy loss, please do that. You can donate on our website. I will say, I don't know if you even know this, Dr. Shah, but our first research gift ever made as an organization was actually to Dr. Lathy's lab, because she's doing really interesting things with genetic testing. So
That's wonderful.
yeah.
That's great. She's really an incredible
Yeah.
person, researcher. She I think she's going to use those resources well.
Oh,
So I'm glad that that went to her.
yeah.
Yeah. Yeah.
So thank you everybody for joining. This will be recorded. I will post it on our feed. Dr. Shah, are you comfortable if people have any questions that we didn't get to tonight? Can they DM you, or
Yes.
you're okay with that?
Absolutely. Please feel free to message me, and you know, I will do my best to get back to you as soon as I can. But my Instagram account is at Dr. DRMEERA_Shah, and I think it's linked on your post as well. So feel free to reach out for anything. And I wish you all viewers out there the best of luck in your own journeys.
Yeah, thank you so much. Have a good rest of your evening, and those of you in all time zones, good rest of your Wednesday night and close to the week.